and sort of ends at the door. That doesn't sound like case management to me if you're not sort of covering all kind of scenarios here in the care. That's obviously suboptimal, and it's going to lead to the situation where there's a much higher probability the individual isn't going to come out of that SNF when they enter it. So I really enjoyed this study and sort of perfectly parallels some of these conflicting incentives we see in the nursing home. Yeah, sure, Larry. Absolutely, and I think it's a classic example of Medicaid, thinking to Medicaid. In addition to the nice quantitative study by Larry's group, there's also a great anecdote. This was a more sort of qualitative study, a review by Eddie Miller, who's now at Brown, and Bill Weissert, who's now at Florida State, who I mentioned earlier. And they sort of were surveying different program officials, and they relate the response of one such official on a proposed program to reduce hospitalizations among Medicaid home and community-based service clients. And the response was, I often say, picture's worth 1,000 words. Well, I think this quote's worth kind of 1,000 data points or something like that. But the response was, why would we want to do that? Those are Medicare dollars. For us, that's development money. We don't want to reduce Medicare expenditures in our state. And I often joke that we could take that last sentence, we don't want to reduce Medicare expenditures in our state, and kind of translate it to Latin and put it up on kind of the state Medicaid. I mean, that really sums it up, doesn't it? I mean, yeah, no, you're not sort of minding the other side of the fence there, and that's a perfect encapsulation of that idea. So I've always enjoyed that quote. So let me give a third example here, and this is sort of cost shifting in the opposite direction from hospitals back to long-term care providers like nursing homes. Obviously, in theory, this should certainly relate that the quality of care, the investment that Medicare is making in hospital services should impact chronic care, nursing home, home health, home care services downstream. It's obviously harder to quantify, and there isn't the big literature here because these costs, these long-term care expenditures are often, I think, years down the road. However, one example, obviously Medicare's adoption of hospital PPS was a big change in the way that Medicare paid hospitals, going from a cost-based system to a prospective payment system, which changed the incentives in 1983. A lot of work showing patients being discharged sicker and quicker from the hospital. Following that, there was this huge growth in post-acute services during the late 80s and into the 90s, kind of this huge increase in all post-acute settings, home health, SNFs. What I think Shaughnessy and Kramer suggest is that there's this transition. Today's SNF patients are often tomorrow's chronic care patients, and so there's this transition. Discharged sicker and quicker, leading to sicker post-acute patients, which ultimately is leading to individuals transitioning into chronic nursing home care, that much more sicker, and obviously on Medicaid's bill. And what Shaughnessy and Kramer found was that chronic care nursing home residents were much more disabled in 1986 following the hospital PPS relative to 1982. Now, one response is obviously that's a pre-post study. Lots of things could have been changing in the world. I'm willing to acknowledge that. But I would think some of this is that sicker and quicker, and that you're certainly seeing some of that spillover down to the long-term care area, and some of it to custodial or chronic nursing home services. So, a final example, and I promised to talk a little bit about mental health care. My colleague I know who spoke here, I think back in October, Tom McGuire, and I are getting very interested in sort of this synergy between mental health and long-term care, which, as Mary and I have been talking over the course of the day, I think is often ignored. And we have those of us that sort of talk about silos here. We have those of us that sort of do long-term care, and those of many of you who do mental health, and we don't often kind of, I think, do a good job of working with one another. And what Tom and I are trying to do is basically address this first point. There's been relatively little, we think, health economics research thinking about mental illness in nursing homes. And I always try to motivate my interest in this area with the statistics at the bottom of the slide. At any given time, there's about 500,000 individuals, and obviously it's how I define mental illness, but 500,000 individuals residing in nursing homes with some mental illness. And that's excluding dementia. I know our prior is often that all nursing home residents have dementia. That's what's really the big ticket item. Well, actually, there's quite a few with some mental illness. To compare that to other numbers, that's about 50,000 in psychiatric hospitals at any given time. And the numbers in nursing homes exceed all other healthcare institutions combined. So I would argue that this is a very important population. These are some data that we have currently under review at Psych Services. One of our postdocs at Harvard is taking the lead along with Tom and I. And just to show you, these are new admissions from the minimum data set, just comparing the number of new admissions with some mental illness. And we define some mental illness as schizophrenia, bipolar, major depression, and anxiety. And then you have the dementias. And just looking at, basically, when you combine the both and the mental illness, only 25% of individuals admitted have one of those four conditions: schizophrenia, bipolar, anxiety, and major depression. 18% have some dementia, and you can see that there's overlap there with 6% of the population. Almost 2/3 have neither a dementia or a mental illness. Keep in mind, lots of short stayers are in these data. So these are never been admitted before to a nursing home. So brand new admissions. Everyone that sort of showed up in the MDS, and we had some other exclusion criteria. But you can see that there's a lot of short stayers mixed in with individuals who transition to long stay, and I'll come back to this transition to long stay in just a moment. And just to show you some trends here. It's hard to see two of the lines here kind of overlap one another at the bottom there, schizophrenia and bipolar, but they're about at a half percentage point. But you can see that anxiety has kind of been around 2.5% among the prevalence among new admissions. And you can see depression increasing from 11% in '99 up to 15.5% by 2005. Probably some ascertainment there. There's definitely some other, a lot of ascertainment, probably so. In paralleling some measurement we've seen in the community as well over that same period. But depression is obviously the big ticket item here, sort of driving mental illness in the nursing home. So thinking about coming back to our topic of sort of conflicting incentives, historically, as many of you know, Medicare coverage for Part B services by psychiatrists, nurse practitioners, PAs, psychologists, social workers was not very generous. And there's a nice piece by the AGS and the AAGP, kind of a statement on kind of quality for mental illness in nursing homes in 2003. They kind of draw out a lot of the policy issues and really focus on the lack of parity at the time. The MIPA legislation in 2008, prior to that, beneficiaries faced a 50% copay for outpatient services provided by non-physician mental health professionals, while other outpatient services required a 20% copay. With MIPA, we now have parity, of course, across the medical and mental health services. The question is will this sort of change go in the other direction? Will we see now kind of maybe better coordination, fewer nursing home admissions, kind of a better coordination of Medicare and Medicaid? Prior to parity, I would suggest that individuals weren't receiving good, kind of Medicare services, either in the community or once they entered the nursing home. Part B would continue as they were in the nursing home sector, but that would contribute, one, to them being admitted to the nursing home, and two, to them having long stay periods in the nursing home, which would leave them on Medicaid. Just to give you something along this is from a paper we have in press at Health Affairs. This is the likelihood of long stay transition. So staying in a nursing home 90 or more days in 2004. And you can see that those with schizophrenia and bipolar, 46% of them